topic is mantle cell lymphoma, and it's Ibrutinib versus Temsirolimus, and its results from a phase 3 study. So I'd like to introduce you to Dr. Simon Rule, who is a professor in hematology, Institute of Translational and Stratified Medicine, Plymouth University in the UK, and the medical director of the Peninsula Cancer Network. Let's talk about the setting for a moment. What's the challenge with mantle cell lymphoma?
So mantle cell lymphoma remains an incurable disease, and of the lymphomas, it's probably the most aggressive subtype. We've got a number of treatment strategies that work well frontline, be that elderly patients or young patients, but they all relapse, and when they relapse, usually it's a difficult disease to treat, and it's knowing what to do in that situation. So there are a number of drugs that have activity in the context of relapsed mantle cell lymphoma, and this study was really looking at two of the targeted therapies, if you like, head-to-head in the context of relapsed patients.
Now you have about 280 patients in this phase 3 randomized trial. Let's talk methods for a moment. Who were these patients and what exactly did they get?
So they're all relapsed patients. They had to have received at least one prior line of therapy with a rituximab-containing combination. It could have been more than one line of prior therapy, and they were randomized 1-to-1 between Temsirolimus and Ibrutinib. And the drugs were both given to progression or intolerance. Some balance there based on MIPI scores and prior lines of therapy. But it's so a very, very balanced group of patients.
So what did you find?
So we found a highly significant benefit from a progression-free survival point of view in favour of the Ibrutinib over the Temsirolimus. Temsirolimus, for an American audience, if you like, is a drug that's licensed and registered in Europe for the treatment of this disease. What was interesting with this trial is that the Temsirolimus is the control arm, but actually the control arm was the best results ever seen with that drug. And despite that, progression-free survival was way better with the Ibrutinib. So a very, very significant benefit from progression-free survival perspective. And despite patients on Ibrutinib getting 4 times the length of drug exposure, fewer significant side effects. So
yeah, that was kind of interesting comparatively. Yeah. I was surprised, and were you pleased at that too?
Yeah, I guess it's not a surprise. I mean, I've used both drugs. We know Ibrutinib's a very well-tolerated drug. The side effects that people have concerns about, the bleeding and the atrial fibrillation, actually weren't that big a deal. And actually, if you adjust for drug exposure time, there are actually no obvious differences in the two arms. So again, that's some reassurance, I think, for people who are concerned about that. And the AFib, particularly, no patient had to stop drugs. So again, it's evidence that yes, you get these problems, but they're maybe not as insurmountable as people might think they are.
So were the patients okay with taking it in terms of, it's not a very difficult regimen?
No, I mean, it's just oral, it's just 4 tablets a day and you just stay on it. So yeah, I mean, my experience with patients, particularly in the relapse setting where they're unwell and they've had a previous experience with chemotherapy, the idea of taking oral medication with essentially no side effects, it's great.
In terms of what's next, obviously future concepts are going to have to investigate dual therapy.
Yeah. So what's next? I'm glad you asked that because the trial opened last week. We now have evidence published last week, actually, from the MD Anderson. The addition of rituximab to Ibrutinib seems to be synergistic, which was very useful for me because I've got a frontline study starting in the UK, started last week, of Ibrutinib rituximab versus chemo rituximab. So that is the trial. Can we use true chemo-free versus chemotherapy frontline in elderly patients with mantle cell lymphoma and show a difference? One of the things I'm going to show tomorrow is that if you use Ibrutinib earlier on, you get much better results than if you use it later on with respect to progression-free survival. Now, if that translates into the front line, we should see some pretty stellar results. The RAY study that I'm talking about tomorrow, rather cleverly, will be published online at the end of the session.
Ooh, very nice.
The Lancet, it's in the Lancet. Yeah.
Terrific. So congratulations. This sounds like a lot of fun. Will you be presenting any more at ASCO? This sounds like it's moving fairly fast.
Yeah, it is. The interesting thing about this study, if you like, is that there isn't as yet an overall survival benefit, although the hazard ratio is 0.76, so it's looking like that might happen. So there will be further follow-up, and I guess there'll be subsequent publications. My study, which I say is just opened, that's going to be very interesting. That's going to be a couple of years before we see any results there, but clearly that's the way things are moving.
Right. Well, for the citations, that's coming up in just a moment, right after I say I'm Rick McGuire for ASH Clinical News.